Good evening, everyone. On behalf of Columbia Global Centers Mumbai, I'm delighted to welcome you today's session. Our center is one of Columbia University's 11 global centers worldwide, serving as hubs for research, knowledge exchange, and collaboration. Today's webinar is the fourth in our Columbia HICC Cancer Series, which we launched last December in partnership with the Tata Memorial Center and the Rajiv Gandhi Cancer Institute and Research Center. It is now my pleasure to introduce our moderator for the evening, Dr. Ravi Kiran Pokala. Dr. Kiran is a renowned surgeon scientist specializing in inflammatory bowel disease, colorectal cancer, and complex colorectal conditions. He serves as the co-director of the Global Center for Integrated Colorectal Surgery and IBD Interventional Endoscopy at New York Presbyterian Columbia University Irving Medical Center, and is also the director of the Center for Innovation and Outcomes Research in the Department of Surgery. We are honored to have him lead today's important discussion. Dr. Kiran, over to you.
Thank you, Racha. Good evening and good morning to all joining from different time zones. I'm P. Ravi Kiran, and it's my privilege to moderate today's session. As Rachna mentioned, this webinar is part of the Columbia HICCC Cancer Series, a collaborative initiative between Columbia Global Centers, the Herbert Irving Comprehensive Cancer Center at Columbia, and our esteemed partners in India, the Tata Memorial Center and the Rajiv Gandhi Cancer Institute and Research Center. Our aim is to foster meaningful dialogue, share clinical insights, and build bridges between experts in India and the United States. This year, the series covered breast cancer, head and neck cancer, and pancreatic cancer. And then today, we turn our attention to colorectal cancer, an area where rapid advances in precision oncology, minimally invasive procedures, and targeted therapies are transforming patient care. We have three outstanding speakers, two who will first speak prior to me, and who will walk us through the critical developments in this field. Our first presenter is Dr. Anbarasan Sekar. He's an associate professor of medical oncology at ACTREC in Navi Mumbai, and he will discuss how ctDNA can guide personalized therapy and improve treatment outcomes. A quick reminder to the audience, please feel free to submit your questions in the chat. We'll take them up during the Q&A at the end. Dr. Sekar, over to you.
Dr. Kiran, thank you for this introduction. We quickly move on to the topic of discussion today, which is ctDNA utility in colorectal cancer. So we all know that ctDNA is a part of cell-free DNA, which is a pool of DNA which is collected from all the cells. Among that, ctDNA also contribute minor fraction of the component, that is around 1%. How this ctDNA coming into the blood? It could be possible because of the cell necrosis, or could be because of active secretion via tumor exosome. And there are several factors which influences the ctDNA level, possibly because of deoxyribonuclease activity, tumor stage, subtype, and metastatic site. And this ctDNA has really very short life. That is why it could be a potential marker to diagnose disease at the point in time. And there are several factors like pre-analytic variables before downstream analysis we should note down. Where the sample is collected, whether it is collected in an EDTA tube or it is conducted in a specific tube for collecting ctDNA purpose. This scores very important value because the timing of storage and all those things forms a crucial important message in it. And the plasma storage is very important if you want to stay. Plasma storage is very important if you want to store it for a long period of time. And we have to analyze how much percentage of cell-free DNA extraction possible from the given sample. When it comes to NGS-based methods for analyzing ctDNA for colorectal cancer, we have two different methods. One is tumor-informed approach and another one is tumor-agnostic approach. Can we go ahead with only one method? No. Both the methods has its own merit and demerits. What is the advantage with tumor-informed approach? How we consider tumor-informed approach? When it comes to tumor-informed approach, we try to take the tissue sample of the patient and then we run a basic NGS testing. It could be whole exome sequencing or whole genome sequencing. Try to identify the patient tumor-related mutation factor in the patient. And based on the patient-informed method of this thing, we go ahead and proceed with distal droplet PCR for the patient, and then be able to analyze the mutation profile in this population. By this way, we able to detect tumor sample as low as 0.001, which is highly informative for the patient. And it also has its own drawback, like patient will require tumor tissue definitely for the analysis of tumor informed approach, and it requires high cost as well as long turnover time. When it comes to tumor agnostic approach, it is non-invasive. It can taken in the blood sample only, no requirement of tissue sample for the patient. And how they do the NGS analysis in this patient, they try to do deep sequencing based on the previously available data on this on the tumor profile in this scenario. So it has own advantage as well as disadvantage because it has very short time and no requirement of tissue for the patient. What is the utility of circulating tumor DNA in cancer? It has wide range of in approval, right from the diagnostic, treatment selection towards treatment response and monitoring. When it comes to diagnostic, we have complementary to tumor sequencing, methylation pattern, all these things are available. And currently, we are going to mainly discuss about tumor response, that is minimal residual disease in this situation. And ctDNA has three main phases to be precise: genotyping, whether you want to give analyze for the EGFR mutation in lung cancer. Similarly, if you want to look for RAS mutation in colorectal cancer, this can be genotyping can be done with liquid biopsy also. For detection of MRD in early stage cancer, especially after completion of chemotherapy. Also, in certain cases, when the diagnostic tissue is not available, in those situations also, circulating tumor DNA has its own value. Circulating tumor DNA for MID discussion. That is our main part of discussion, where we can consider this MID discussion. That is which stage of disease we can consider for this MID based discussion. Initially, we can consider when the patient is after surgery, we can consider for the dissection. So we can decide whether we want to give adjuvant treatment or not in this population, as well as we can consider as a serial monitoring, as a longitudinal monitoring for the patient. So during the sequence of the treatment, we can analyze the ctDNA positivity based on which we can determine the treatment possibilities. Also, in metastatic disease, we can determine the outcome based on the presence of ctDNA positivity in this population. What is the percentage of ctDNA positivity in general? When it comes to ctDNA positivity, this is one of the bespoke study. The percentage of ctDNA positivity varies from 15 to 80 percentage, depends on the stage of the disease, depends on the type of study, depends on the regional location also. This bespoke study done, which has shown that MRD positivity in stage 2 and stage 3, where MRD positivity in stage 2 is close to 18%, in MRD positivity in stage 3 it is 75%. We discussed MRD at three different levels. That's how the staging has been, that's how the studies have been evolved in this MRD based evaluation colorectal cancer. In level 1 as a prognostic marker. Why ctDNA serve as a prognostic marker? This was answered by John Hopkins study 7 years ago, where they tried to analyze the role of ctDNA positivity in a colorectal cancer patient in early stage colorectal cancer patient. What they found out here is when the patient is having ctDNA positivity, they have higher chance of recurrence compared to those patients who are having ctDNA negativity. And we have multiple other studies to support this finding, because other studies has not only shown progression-free survival for ctDNA negative population advantage, also it has shown overall survival advantage. And also we have two different meta-analysis, again re-emphasizing the fact that whenever ctDNA positive is there, it is associated with poor outcome in terms of both decrease in progression-free survival as well as decrease in overall survival. And it also shows one important factor that whenever ctDNA positive remains after completion of adjuvant chemotherapy, this again determines very poor prognosis for the patient. How ctDNA stands compared to the other markers in this scenario. When it comes to ctDNA, it actually overcomes all the other markers like presence of nodal disease, tumor staging, and LVA positive, any other high-risk features. It definitely overcomes, and definitely it is better compared to the other markers in this scenario. So ctDNA in the initial stage, proving its role as a very good prognostic marker. This is one of the largest prospective study done in Japan, ctDNA in colorectal cancer in Galaxy cohort. It includes multiple stages from stage 1 to stage 4 population are also relapsed colorectal cancer, and then they tried to monitor longitudinally ctDNA positivity in this population. There were few important results to discuss with regarding the Galaxy study design. What they found out is Irrespective of the stage, when the patient is having ctDNA positivity, they have poor prognosis compared to the ctDNA negative population, and the ctDNA positive rate also varies according to the stage of the disease in which they are presenting. Obviously, stage 4 have very high percentage of ctDNA positive in this scenario. Second important factor they try to see is when they monitor ctDNA longitudinally, whenever the patient having transient positivity or patient having ctDNA negative, this subset of patient behaves better compared to those patients who are persistently positive or negative to transformation from negative to positivity. Comparatively, these patients, this worsen in this subgroup of population. Another important factor also holds very important value for ctDNA in colorectal cancer, that is percentage of tumor fraction positivity for ctDNA. Whenever the higher percentage of ctDNA fraction is positive, they have very poor survival compared to those of limited number of ctDNA tumor fraction positivity. Coming to the level 2, where ctDNA used as a testing for the test. That means we are trying to utilize the ctDNA as a marker of test for the colorectal cancer, and then based on which we are trying to see whether how we are able to identify the treatment in this population. This is one important study, Galaxy dynamic study design, dynamic 2. It has 5-year survival data also. The primary endpoint over here is try to see for recurrence-free survival at 3-year point in duration. Here they try to randomize the patient, 455 patient, randomized 2:1 ratio into ctDNA based treatment cohort and standard treatment based cohort. In a ctDNA based cohort, they try to see for ctDNA positivity. In those, they determine treatment based on the clinical judgment in this population. What they found out is whether it is ctDNA based or non-standard DNA based treatment, that recurrence-free survival is almost similar in the subgroup of population. There are certain drawbacks when it compares to utilize ctDNA based monitoring in this population. What are the drawbacks? Even the tumor T4 stage, the outcomes are similar for ctDNA positive as well as ctDNA negative. But what they found out is the percentage of oxaliplatin utilization is close to 62% in ctDNA positive cohort, whereas it is 90% of population in standard cohort utilized only 5-fluorouracil based single agent based treatment in the cohort. So there is a sharp deviation in the utility of chemotherapy in the uh, colorectal cancer patient who are stage 2 between ctDNA positive and ctDNA negative cohort. Another important drawback for or slight drawback for the patient with ctDNA in dynamic 2 study design is uh, in the ctDNA positive patient, if they have T4 disease, they have poor outcome, which is something similar to the ctDNA negative cohort also. So again, T4 disease plays a very important role. When the patient is having locally advanced disease, they have higher percentage for disease recurrence, irrespective of ctDNA positive or negative. Coming to the dynamic 3 study, the results of dynamic 3 study published recently with a follow-up duration of 47 months. Here they try to analyze the result of stage 3 colorectal cancer. In stage 3 colorectal cancer patient, they try to analyze the factor for ctDNA positive as well as ctDNA negative, and based on which they try to escalate and de-escalate treatment. Whenever the patient is ctDNA negative, they try to go for observation. Whenever the patient is positive, they try to escalate the treatment. Unfortunately, the primary endpoint includes both ctDNA positive cohort and ctDNA negative cohort, but both the primary endpoint were negative. But it has its own positivity also. In ctDNA negative cohort, it just missed the uh, statistical significance by a mere fraction of 0.5%. Here, whenever the patient is having ctDNA negative, in the standard cohort, it is 88.1. In the ctDNA guided management cohort, it is 85.3. It narrowly missed the non-inferiority boundary of 2.5%. So it depends on the clinical situation. If you feel the patient condition is little bit difficult to take for chemotherapy, then often you can consider for ctDNA based observation also in this scenario, because it has nearly similar in this scenario. Usually we often keep the non-inferiority boundaries 10% margin. Here they try to be more ambitious. That's why they kept the non-inferiority margin of around only 5%. When it comes to ctDNA positive cohort, it is done in phase 2 as well as phase 3. In phase 2, the result is not showing any significant advantage. So we need to wait more time to analyze for the ctDNA positivity in phase 3 part of the study design. Coming to the next part of study design, where they try to utilize ctDNA, and then they try to, based on the result of ctDNA, they try to modify the treatment accordingly in this subset of population. There are several studies starting from Pegasus, Galaxy. The Galaxy is a very large study. It includes both Vega as well as Altair study design. In Vega, they try to de-escalate the treatment, and Altair, they try to escalate the treatment if the ctDNA is positive. And Pegasus is again one of the important study we subsequently discussed over a period of time. And another interesting study design is SU2C AC T3 study design, where here what they try to do here is they try to give chemotherapy for the patient whenever the ctDNA positive. They try to see for the biomarker positivity is there or not. When biomarker is negative, they try to go with standard chemotherapy for the patient, either with fall-free regimen. Whenever the biomarker is positive in those subset of patients, they try to utilize biomarker in this population. One reason why this ctDNA not going impact in terms of survival outcome because of this biomarker positivity. So in future, we are trying to answer these questions in the future trial based on the SU2C as well as segregated study, which is in UK-based population. Next important factor is whether ctDNA guided de-escalation of treatment will be beneficial in the population or not. Pegasus is one of the important study where they include the cohort of population with stage 3 as well as high risk stage 2, that is T4N0 into the study design. What they found out here is time to relapse according to the clinical stage and ctDNA. The time to relapse according to ctDNA able to differentiate much better compared to the clinical stage also. This is one of the advantage of using ctDNA in the population. Second thing, they try to see whenever the patient is ctDNA positive, they try to, after 3 months of KPOX, if they remain still ctDNA positive, they switch the therapy to fall free. Whenever the patient switch the therapy to fall free, the seroconversion rate is close to 40%. Again, it is giving glimpse of hope that we can consider modification of treatment when the patient is having ctDNA positivity. The other important data is there is a subset of patient, like 8% of population in the Pegasus study, when the patient is having ctDNA negative, still they try to have metastasis. Where this patient had metastasis, most of the time these patient had metastasis in the lung and peritoneum. Obviously, the reason behind ctDNA negativity is because of the lack of blood supply for the peritoneal region. That is the reason whenever the patient is having lung or peritoneal metastasis, they have ctDNA negativity. But when the patient is having ctDNA positivity, most of the time they have recurrence in the liver. This is also one of the important finding. It is not only established in the Pegasus study, it is also subsequently seen in other study like Dynamic 2, which is done in the rectal cancer. Again, in ctDNA negative, large cohort of patient had metastasis in the lung and peritoneum. In patients who are having ctDNA positive, large cohort of patient having metastasis in the liver. Next, ctDNA guided treatment modification. Pegasus study has given slight idea where we can able to modify the treatment, but it has not as a full-fledged trial. Here is one of the important study, CalGB SWAG 80702, where they try to analyze the utility of celecoxib addition along with chemotherapy in the population. They also analyze the ctDNA positivity in this population. Here you're able to see the Kaplan-Meier curve, 4 different curves in the population. Initial 2 curves hugging each other, where the ctDNA negative population, one arm utilized celecoxib and another arm utilized not given celecoxib. Whereas the below 2 arm, the clear separation is seen. The above blue, light blue arm is the arm where ctDNA positive, where they try to utilize celecoxib in this population. Whenever the ctDNA positive patient utilize celecoxib, the 3-year survival advantage goes to 41%. In the placebo arm, it is only 22%. There is absolute difference of 13% advantage is seen when we add celecoxib for the ctDNA positive patient. Coming to the other important aspects, like where we utilize ctDNA in other areas like deficient MMR population. We all know that Night 2 study design where they utilize the role of combination of immunotherapy in this situation, where they said that even 2 cycles of chemotherapy is sufficient to produce good amount of pathological response in this subset of population. What is another important factor is whenever the ctDNA clearance is very rapid, these patients tend to have higher response rate compared to those patients who tends to have ctDNA positivity. Also, the ctDNA positivity rate is even as early as 1 cycle of immunotherapy, close to 45%. When they given 2 cycles of chemotherapy, ctDNA clearance goes up to 83% in this situation. This is one of the another interesting study where they tried to see for wait and watch approach in rectal cancer. in deficient MMR population, when the patient is having ctDNA negativity, in a small cohort of population, they try to avoid surgery, and 4-year survival advantage is still there, close to 93%. The relapse-free survival rate is seen, which is encouraging in this subset of population. Coming to other utilities of ctDNA in rectal cancer patient, compared to colon cancer, in ctDNA utility in rectal cancer is still in a preliminary stage, where the presence of ctDNA both in pre-op as well as post-op has a prognostic value. Unlike ctDNA in colorectal cancer, ctDNA positivity doesn't correlate well with the PAT-CR rate, something we need to note it down. So they are trying to utilize ctDNA along with MRI-based evaluation for such population to analyze the prognostic value for the ctDNA study in this subset of patient. Next comes the ctDNA in screening purpose also. So we have seen ctDNA as an important marker in terms of MRD-based evaluation in stage 2 and stage 3 colon cancer. It has a role in rectal cancer, in a small bit of role in deficient MMR population also. Now we are moving to the ctDNA utility in screening. When it comes to screening, there are several tests are there which able to have sensitivity close to 70% with a specificity close to 95%. But one drawback why we are not utilizing ctDNA in colorectal cancer is the ability to identify precancerous lesion is only less than 20% in majority of the study. Either it is peak study design, GRACILE study, or it is SHIELD study design. The precancerous lesion detection rate is 11 to 15% in this scenario. Whereas when they are able to detect cancers rate is close to sensitivity of 70% and specificity close to 90%. So what they are trying to utilize is they're trying to see for other multiple cancers detection in a single blood sample. They are trying to work it out. Coming to the last part of the study, there are very good key takeaway point with respect to utility of ctDNA in this study design. Whenever the patient is having ctDNA negativity as well as low clinical risk factor, we can safely consider for surveillance in this scenario. But if the patient is having ctDNA positivity, irrespective of clinical pathological factor, you should recommend for adjuvant chemotherapy, because even in Galaxy study design, what we observed is when the patient is ctDNA positive, we have given chemotherapy. These patients tend to do better compared to those patients who are in observation arm. Next, when the patient is having ctDNA negative and high risk feature is there, then discuss about the option of adjuvant chemotherapy in the subset of population. Currently, ctDNA has not much role, especially the dynamic study failed both in the CT positive as well as negative cohort. So we recommend adjuvant chemotherapy in this subset of population. With this, I would like to thank for giving me this opportunity. Thank you, everyone.
Thank you, Dr. Sekhar. And our next speaker will be Dr. Jaskaran Singh Sethi. He is the Senior Consultant and Chief of GI, Genitourinary and HPT Radiation Oncology Services at the Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Sethi will be speaking on short course radiotherapy in the era of total neoadjuvant therapy, evolution, evidence, and emerging practice. Dr. Sethi, please go ahead.
Thank you, sir, for the kind introduction. I'll just share my slides and start the presentation. So, my screen is visible.
Yes, it's visible, but the volume's a little low.
Okay, I'll just. So is it okay now? The volume?
It's better, yeah.
It's better. Okay. So after a wonderful talk by my colleague from ACTREC, Dr. Sekhar, I shall be pondering upon what is the role of short course radiotherapy in the era of TNT in today's world. So before we start off, let's just briefly see the evolution of
The volume's still a little low. Sorry, Dr. Sethi, to interrupt.
Okay, I'll just try to make it more. I am at max now. Is it audible?
It's better, yeah.
It's better. Okay. So let's see how the evolution of treatment for managing rectal cancers has evolved over the last few decades. So we all know that surgical skills have evolved from the primitive surgeries to TME, which Dr. Ravi is going to elaborate in his talk after me. There have been a lot of developments in the field of medical oncology. We just heard Dr. Sekhar uh, pondering upon the latest advancements with the help of ctDNA, deciding the treatment with ctDNA. The treatment is no more just stage based, but it is based out of the molecular signatures of the disease. And so radiation has also been over the decades found its way in the multimodality treatment of rectal cancer treatment. So what we have seen that there were trials which were conducted in the pre-TME era. These were the Stockholm trials, Stockholm Cancer Study Group trial, the Stockholm 1 trial, and the Swedish rectal trial, which pondered upon whether radiation was useful in the treatment of rectal cancers or no. And what they found was that short course radiotherapy did have a effect on the response loco-regional recurrence rates, and it brought it down from 20 to 30% in the surgical alone arms to about 10 to 15%. These high recurrence rates in the surgical arms were also perhaps indicative of the poor surgical techniques or the primitive surgical techniques that were used in the pre-TME era. Then the TME came, and it was then again few trials had to be done to see whether radiotherapy had just compensated for a primitive surgery, or whether in the era of a better surgery is there any role of radiation. So two trials touched upon this topic: the Dutch TME trial and the MRC CR07 trial. And both these trials again showed that radiation, which was given preoperatively to TME, was effective, and that the loco-regional recurrence rates came down to almost half. So it was concluded that although no overall survival benefit was seen, but these were the radiation was a important tool in the treatment of rectal cancers. Uh, at that time, actually, radiation was used more as a post-operative treatment or an adjuvant treatment after surgery. So, German rectal cancer trial pondered upon whether it should be given pre-operatively or post-operatively, and they did this trial, a two-arm trial, with surgery upfront followed by chemoradiation followed by adjuvant chemotherapy, versus chemoradiation followed by surgery and adjuvant chemotherapy. So what they found, hello, my slides have just stopped. Okay, so am I audible still? Hello.
Yes, you are.
Yeah, somehow my slides have just stopped. Okay, so what they found out was that pre-op chemoradiation as compared to post-op chemoradiation, it was better to do pre-op chemoradiation because it improved the local control and it was associated with reduced toxicity. Although it did not improve the overall survival in the post TME era, it did not improve the overall survival, but the increased rates of sphincter preservation were observed. So this actually, the pre-op radiotherapy or the neoadjuvant radiotherapy as we know it, is the trials actually clinically collaborated what the theory said, that it is better to give pre-operatively because there is a greater possibility of a sphincter preservation as the tumor size reduces. As from radiation oncology perspectives, it was important to give it preoperatively because we could use smaller fields with less irradiation of the small bowel and hence lesser toxicity of radiation. The tissue was better oxygenated pre-surgery, and so that theoretically gives greater efficacy to the treatment by radiation. And but the possible disadvantage was that we were treating patients, over treating the patients who had early stage disease or who had metastatic disease, who may not benefit from the addition of radiation. And the mainstay or the mainstay treatment of surgery was getting delayed. So, Stockholm 3 trial actually pondered upon further whether we should give preoperatively and do immediate surgery, or we should give preoperatively and then delay the surgery. Because when the surgery was done immediately post radiation, in the earlier trials, it was seen that the reduction of the tumor was not good. So it was a three-arm study. It was a non-inferiority trial of 840 patients, which studied the tumor regression grades, the pathological complete rates, the overall survival, and the time to recurrence. At 5 years, they concluded that there was no overall survival or DFS benefit by giving between any of these arms, and the post-op complications were almost similar. So they said that short course radiotherapy with delayed surgery yields the same cancer control as long course radiotherapy with fewer post-op complications. On the question of interval between surgery, they found that tumor downstaging was better after short course radiotherapy with delay, and the patients who achieved a pathological complete response or a DORA grade 4, they were associated with a better overall survival. So, another group from Lithuania also pondered upon this study of preoperative short course radiotherapy or long course chemoradiotherapy, but this time they had a delay in both before surgery, and they concluded that the maximum interval after short course radiotherapy needs to be longer, and it should be about 12 weeks from the start of treatment to have better uh, downstaging of the disease. TNT, we are practicing neoadjuvant chemoradiation followed by surgery. Usually, after long course, the surgery is planned 6 to 8 weeks after mm, the finishing of long course radiotherapy. And in short course, when short course radiotherapy is given, then we for early stage, the surgery can be done early, but normally when the stages are higher, for higher stages, we need to delay the treatment. A meta-analysis was done in China, which also concluded that uh, uh, based on the better pathological outcomes and fewer post-operative complications, it is better to do short course radiotherapy with delayed surgery more than 4 weeks. I'm not getting into what are the advantages of long course and short course, or what are the disadvantages. So let's go to the practice changing trial with regards to long course radiotherapy had two arms: short course radiotherapy, 5 gray, 5 or 25 gray total cumulative dose over 5 fractions, versus the capecitabine-based chemoradiation or the long course radiation, followed by 6 cycles of capox or 9 cycles of Folfox in the short course arm, and followed by the TME surgery in the long course arm. After the surgery in long course, the patient was given 8 cycles of capox or 12 cycles of Folfox. And in the short course, the total surgery in the form of TME was done. The primary endpoints here were disease-related treatment failure, and the secondary endpoints were overall survival or zero rate of resection, the pathological complete response rate, toxicity, and surgical complications. So at 3 years, when the initial results came out, it was seen that the disease-related treatment failures were much higher in the long course arm versus the short course arm. Diarrhea was also higher in the long course arm. So they concluded that the short course arm with a delayed surgery was with chemotherapy and delayed surgery was better. They also found out in this that there was almost doubling of the pathological complete response. So which opened up a window for organ preservation in these patients. So, but at 10-year follow-up, at the 5-year follow-up, sorry, they found that the loco-regional recurrences were much higher in the short course arm as compared to the long course radiotherapy arm, 10% versus 6%. And so the conclusion was that probably Rapido trial did not achieve its primary objective because of the higher locoregional recurrences that were explained by number one, that the biological equivalent dose was probably not as high as it is possible to give in long course radiotherapy. At the same time, Project trial came out from the French group, which updated its 7-year follow-up data, and it showed that the overall survival benefit was there when you gave long course radiotherapy after induction chemotherapy with modified FOLFIRINOX prior to surgery. Another trial which was done with short course radiotherapy was a sterile trial from China, which was conducted between 2015 and 18, almost 600 patients. They were randomly assigned to receive TNT or chemoradiotherapy, and they found out that at median follow-up of 35 months, the 3-year disease-free survival was 64.5% in the TNT arm and 62.3% in the CRT arm. And they also found out that the toxicities, although they were higher in TNT arm, but the responses were better. So short course, they concluded that short course radiotherapy with preoperative chemotherapy followed by surgery was effective, and it was with acceptable toxicity and could be used as a alternative. So let's look at what NCCN guideline today tells us. So it tells us that in locally advanced rectal cancers, there is an option of giving long course radiotherapy or short course radiotherapy, and this should be followed by chemotherapy in tune with the TNT or CRT option that the patient has, followed by surgery. ESMO also voices similar guidelines. It says that for higher risk criteria or the ugly tumors, TNT is the way forward, whereas for the earlier or intermediate stage patients, you can do neoadjuvant long course radiotherapy with chemotherapy followed by Capox or Folfox, or you can do neoadjuvant short course followed by the surgeries. So at RGCI, we've been doing short course post COVID times, and I just share that we started analyzing our data. So this is the data from 2019 to 2022 with a cutoff at 2023 December, and a total of 202 patients were given short course radiotherapy. Out of these, 103 had positive CRMs on baseline MRI. 53 of the 103 had positive CRM because of primary, and 50 had because of the nodal positivity. Out of the 103, 62 patients were evaluable, and what we found out was that after surgery, the negative at the time of the pathological CRM after surgery was negative in about 95% patients. And our PCR rates were around 29%, which is almost in tune with what the world literature says. And we had one distant failure, and there were all the patients were actually at this time, with a median follow-up about 2 years, were not having any loco-regional recurrences. So with that, I would like to conclude my talk, and thank you very much.
Thank you, Dr. Sethi. Wonderful to hear the evolving practices in India. From a US surgical perspective, I'll now share updates on cutting-edge surgical techniques that are transforming colorectal cancer management. I'll share my slides.
Hello.
Are you able to see my slides okay?
Yes, they seem okay.
Yes, sir. Slides are visible.
So as we know, colorectal cancer affects 1 in 4 males and women. It's the third most cancer. It's the second most common cause of death due to cancer. Standard therapies include surgery, radiation, chemotherapy, immunotherapy. Despite this, half the patients develop incurable recurrent disease. Most of the emerging therapeutic approaches that are exciting are non-surgical at this current time. The objectives for my talk today are to give an overview of the evolution of cutting-edge approaches over time that transform surgery for colorectal cancer over the years, talk about the role of open laparoscopic robotic surgery and a little bit about local resection, and also some reconstructive options for ultra-low cancers. As we all know, open surgery helped establish the principles of surgical treatment of colon and rectal cancer. These include extent of resection, which means en bloc resection together with high ligation and removal of the lymphovascular drainage basin, removal of a minimum of 12 nodes, the importance of the lymph node ratio, importance of a no-touch technique that doesn't disrupt the tumor cells into the vasculature, and the importance of surgeon technique, often guided by surgical training and volume. Bill Heald specifically emphasized through his results and technique the importance of TME. Operating in the holy plane, as you can see on the picture on the right, helps preserve the mesorectum and reduces the risk of local recurrence. This is a picture of a well-performed TME specimen wherein the mesorectum is smooth and glistening and has not been disrupted. Similarly, when there is T4 disease, en bloc resection while continuing with the TME dissection helps minimize local recurrence. The elegance of and the importance of a technique was established when this study in Norway compared GI surgeon specialists doing rectal resection. Those who had supervision of TME training by Bill Heald, as revealed in the column on the right, had significantly lower local recurrence, 4% versus 9%, total local recurrence with and without metastasis, 6% versus 12%, and better 4-year survival, 73% versus 60%, when compared to a group of surgeons who perform non-TME resection. Phil Quirk and Leeds simultaneously demonstrated through pathologic specimens the importance of TME. On the top, you can see a well-conducted TME, whereas on the bottom, you can see the specimen that is extracted and analyzed when a non-TME dissection is performed. The German trial that Dr. Sethi mentioned suggested that the preoperative chemoradiation provided much better outcomes in terms of local recurrence compared to postoperative chemoradiation. This Kaplan-Meier curves shows 13% versus a 6% recurrence rate for the two groups. How does this then translate into TME? As you can see on the column on the left, when TME is well performed, as shown by Bill Heald in 1986 in the Mercury group, you can have a local recurrence rate of 4% and 3% with surgery alone. On the right, you can see the results of TME combined with radiation. In the German study, there was a 6% rate of recurrence with preoperative chemoradiation, and the MRC CR07 in 2009 showed also a 4% recurrence with preoperative chemoradiation. The conclusions from this study perhaps suggest that radiation, preoperative or postoperative, may control for some of the drawbacks from poor surgery. And if it needs to be performed, it's better performed preoperatively rather than postoperatively. We are well aware of the benefits of laparoscopy, which includes earlier recovery, return of GI function, reduced length of stay, smaller incisions and hence less pain, better cosmesis, and hence wound infection. The drawbacks, of course, are learning curve and operative time. Several studies looked at the efficacy of laparoscopy for colectomy over the years, as enumerated on this slide. The LACI study from Spain, COST study from the USA, COLOR trial from Europe and Scandinavia, and the CLASSIC trial from UK, the last of which actually also included rectal cancers, established the role of laparoscopy in colectomy. This Kaplan-Meier curve from the MRC CLASSIC trial shows that the overall survival of patients after an open and laparoscopic surgery are comparable, and conversion is unfortunately a poor risk factor. So if laparoscopy is utilized, it should be done well and with a minimal conversion rate. Most of these trials, however, excluded transverse colon cancers, T4, M1 cancers, patients who had previous colon surgery, those with severe medical illness, such as the COST trial, and those who were obese in the COLOR trial. And the findings of these studies basically showed that the conversion rate could vary from 11 to 25% for colon cancers, and up to a third of patients could have this for rectal cancer. However, comparing laparoscopic and open colectomy, lymph node harvest, complications, overall survival were all equivalent. And as expected, length of hospital stay was lower for the laparoscopic group. Subsequent studies have confirmed the role of laparoscopy even for transverse colon cancer, which were initially excluded. I've just briefly highlighted that there were no difference in complications or recurrence between the two groups. Eventually, the evolution of laparoscopy for the resection of rectal cancer proceeded with various studies looking at it as listed here. The COLOR 2, CLASSIC, Korean, Lujan, ECOSOG Z6051, and the a la carte studies. Sort of a busy slide, but as I have shown here, the Lujan trial was really the only exception which showed significant differences with a higher risk of recurrence in the laparoscopic group. All the other studies, as you can see, the circumferential resection margin positivity, as well as the distal margin positivity, there was really no difference between the two groups. So all the studies basically concluded that laparoscopy was non-inferior to open surgery for rectal resection and rectal cancer. The long-term outcomes from 3 different studies, the CLASSIC, the Korean, and the COLOR 2, showed that local recurrence, overall survival, disease-free survival, quality of life were all also similar. More recently, we've embarked on robotic surgery, the robotic approach to help laparoscopic surgery. And studies have basically shown that compared to open surgery, recovery benefits are maintained for robotic surgery. And compared to laparoscopy, the robotic approach gives us better visualization with a 3D view. The surgeon can control the camera. There's the ability to rotate and articulate the instruments, and there's some haptic feedback. The drawbacks, however, that there's a lack of tactile feedback and the issue with operating time, costs, and learning curve. The rollout randomized control trial compared laparoscopy to robotic surgery for rectal cancer, and as illustrated here, did not show any difference in terms of conversion to open laparotomy or the circumferential resection margin. The real study was reported from China and looked at a large group of patients, comparing more than 500 patients in the robotic and the laparoscopic arms. And the conclusions were that at 3 years, the local regional recurrence was better with robotic surgery at 1.6% versus 4% for laparoscopic, while the overall survival was similar. The study also found better urinary sexual and bowel function at 6 months after robotic surgery, and for urinary and male sexual function at 12 months after robotic surgery. Once again, this meta-analysis included all the studies that compared laparoscopic and robotic approaches for rectal cancer. As can be expected with any systematic review and meta-analysis, the results are driven by the two largest studies, which include the REAL study with 500 plus patients and the ROLA study with 200 plus patients. And basically, this is what were the final results. The complication grade, mortality, and the anastomotic leak in the forest plot, as you can see, were comparable between the two groups. Shifting gears a little bit, there was a fair amount of interest and excitement in the early 2000s with regards to local excision, but the general data is that local excision needs to be preserved for the only very early T1 cancers because of a high risk of recurrence. And this can either be performed by means of transanal excision or by means of transanal endoscopic microsurgery or transanal minimally invasive surgery, depending upon the platform that's used, and as shown on the right. There was also growing excitement with the role of transanal total mesorectal excision. However, a study from Norway showed that the recurrence rates are very high with this technique, which led to the loss of interest in the technique over more recent years. What continues to evolve is the total mesocolic excision, as was described by Hohenberger from Germany, and the role of central vascular ligation, which continues to be performed and continues to be a matter of debate. Other areas that have not completely been delineated include the adequacy of the distal margin for rectal cancer. Perhaps in some circumstances, a sub-centimeter distal margin might also be adequate, as we showed in the study in 2011. Patients with margins even less than 0.5 centimeters might have good long-term results in terms of local recurrence, provided all the other tumor characteristics are favorable, as shown on these Kaplan-Meier curves of the local recurrence on the left and the disease-free survival on the right, which were not statistically significant. There was some interest in the early 2000s about radio immunoguided surgery, the use of radio immunoguided ways of identifying cancer, and whether that would improve the survival and recurrence rates. However, this was more experimental and did not bear fruition. Briefly shifting gears to the novel approaches to restoration for distal rectal cancer and anastomotic complications. Traditional reconstructive options for very low cancers include an intersphincteric proctectomy or the TATA procedure when adequate margins can be adopted but an ostomy can be avoided, or the use of a colonic J pouch or a coloplasty to improve quality of life of patients. In some advanced conditions, we could also do other techniques as shown pictorially here, a sleeve advancement technique wherein early cancers can be resected and the colon can be brought down for coloanal anastomosis, or on the right, a Turnbull cutate procedure usually used for complications that develop from radiation after leaks. Basically, the patient has a colon that is brought out of the perineum and is mature about 6 weeks later, so that it avoids a permanent colostomy. Another option that is available for patients with ultra-low cancers where restoration of continuity through the normal route may not be possible could be, but continence can be achieved through a continent ileostomy or a K pouch, which basically consists of a reservoir created over the small intestine that is brought out of the abdominal wall, as you can see on the picture on the right, that the patient usually intubates 2 or 3 times a day. This is a picture of the same. I have an interest in creating the continent ileostomy, and we recently published our results, as you can see on this table, of one of the higher numbers of patients who underwent a K-part creation. Most patients have an extremely good quality of life, and this would be a good option in patients with very advanced distal cancers where restoration and APR might be the only possibility. So in summary, colorectal cancer, the surgery is the mainstay, or was traditionally so. Of late, watch and wait and immunotherapy as potential options have revolutionized its management. Surgery has helped evolve principles, and of course, there have been cutting-edge approaches and techniques. The importance when using surgery for colorectal cancer is to balance cure versus quality of life with reconstruction. Multidisciplinary management is key. Thank you. I would like to go on to thank all our speakers for the rich presentations. We'll now open the floor for questions. Please continue to add them in the chat, and we'll address as many as possible in the time we have. I have one question here in the chat. This is for Dr. Sekar. Dr. Sekar, does NCCN approve starting treatment based on MRD detected on ctDNA? Would you like to answer that? This is a question for Dr. Sekar.
Hello.
So, question for you from the chat: does NCCN approve starting treatment based on MRD detected on ctDNA?
No, Dr. Kiran. Currently, NCCN is not approving the MRD testing in colon cancer, but there is a FDA approval is there for signature testing.
Thank you. And then we have another question for you. Will there be a lead time bias for overall survival if treatment starts based on ctDNA versus treatment starting on appearance of macroscopic disease?
So there are trials that are ongoing to see the beneficial effect. Like I mentioned, Pegasus study is the one which has shown that modifying the treatment based on ctDNA persistent positivity has shown benefit. 40% seroconversion rate is there. We need a longer follow-up to tell whether it is benefiting or not. There are early signs are there, it is showing beneficial effect.
Thank you so much. And Dr. Sethi, I have a question for you. Which one would you consider the bigger game changer, TME or MRI?
Well, I think both of them have been big game changers because TMI actually brought down the local recurrences from those seen earlier, as I showed you in the studies, from the Swedish to the pre-TME to the post-TME. And MRI, I think, is very important and vital in today's era to plan the treatment for the patient, to stage the patient properly and then plan the treatment for. It helps us as radiation oncologists to deal with volumes, and we can't do without MRI as radiation consultants. I think even surgeons on MRI they are planning.
While we have you, I have another question for you, which is, what is your algorithm as to when you choose short course radiation?
Well, we in COVID times, we switched our practice a lot to short course, and practically all patients were getting short course. But we would actually opt for short course more frequently than we opt for long course in our center. Most of the times when the patient is not fit for concurrent chemo radiotherapy, is the time when short course is preferred. And also in elderly patients, I think we should prefer short course over long course. Also the patient logistics also. And in a resource restrained country like ours in India, where when we can do the same job in 5 days rather than 25 sittings or 5 weeks, it makes sense to go with short course more often.
Then I have a question for Dr. Sekar. Which do you think is would you be your algorithm? Would there be a role for a ctDNA in stage 2 disease? If it is, for example, if the ctDNA might suggest when to use chemotherapy, adjuvant therapy, and then similarly in stage 3, would you hold off adjuvant therapy if ctDNA was negative?
Yeah, in stage 2, if the ctDNA is negative, I would like to withhold the chemotherapy because there is a good enough data to suggest that ctDNA negativity responds very well as like to the standard treatment terms. Whereas in stage 3, dynamic study is negative. So I'm looking for more data to implement in the stage 3 colon cancer patient.
And say you had a patient who had colon cancer stage 2 and ctDNA becomes positive. What is your usual algorithm to management of that?
For a stage 2 colorectal cancer with ctDNA positivity, I would like to go with the CAPOX regimen. Doublet will be my choice. Even in dynamic 2 study, they utilized almost 60% of patients who were ctDNA positive. They used doublet regimen in this scenario.
So basically, if someone is becomes ctDNA positive, you would treat them?
Yes, I will treat them. Even in Galaxy study, it has shown that ctDNA positivity, when the patient is treated, they did much better compared to those who observed after ctDNA positivity. So there are a couple of studies show that if ctDNA is positive, better to treat the patient.
Thank you. And Dr. Sethi, in terms of long-term chemotherapy and radiation, are there any specific circumstances where you think you should absolutely do only that and not consider short course radiation?
Well, I think if I have to do long course, it would be in patients who are not fit for chemoradiation, or maybe as the data from Rapido has just shown that there was a increased loco-regional recurrences. So all those patients probably who are very advanced can be candidates to be taken up for long course. As of now, the data is starting to support long course.
Thank
Patients with
you.
MVI or very heavy nodal burden, I would prefer to go with short course for early initiation and exposure to chemotherapy, where distant metastases are more common. But for bulky diseases, T4s, I think long course is making a comeback very strongly, or is.
Thank you. Any more questions from the audience? Since there are no further ones, I think we can conclude this session. Thank you to all our speakers for their outstanding contributions and to our audience for your engagement. This session brings us to the close of this year's Columbia HICCC Cancer Series. We hope these exchanges continue to strengthen partnerships and knowledge sharing across borders. We look forward to reconvening next year and we'll share details of the upcoming sessions. Rachna, back to you.
Thank you. Rachna has logged off another meeting, but I really want to thank all the doctors present today and to Dr. Kiran and Dr. Sekhar and Dr. Singh for engaging in this webinar and sharing your expertise. And we really appreciate you giving time for this engagement. Thank you so much. Thank you, everyone. And we'll share the recording along with some key takeaways after the webinar. Thank you so much.
Thank you.
Thank you.